Hey everyone. Hey everyone, we're just going to give people a couple more minutes to join us, but I want to be cognizant of your time and not go too late. So if you can bear with us, we'll start in a couple of minutes and I'll do all the introduction and everything.
For folks who may be watching on the NASW New Jersey Facebook page, we are live streaming this webinar to the NASW New Jersey Facebook page. And if you're watching live, you can enter your questions in the comment fields on Facebook, and we'll transfer them into the main Zoom webinar.
Give everyone one more minute to join us. Really happy to see people. This is going to be a great session. So thank you for taking the time to join us. We'll give everyone one more minute and then we'll get started. All right. Oh, hang on. A couple more people coming in. Hi, everyone. My name's Helen French, and I'm the Development and Continuing Education Director at the National Association of Social Workers in New Jersey. Very warm welcome to everyone for this community conversation sponsored by Rutgers. Thank you very much. We are going to be talking about today treatment considerations for people with opioid use disorder in New Jersey's rural communities. We are thrilled to be joined by Dr. Jamey Lister, who is a professor at Rutgers, but also has secured funding, is funded by SAMHSA for their opioid use disorder centers. And there's one in each state, but it's kind of a big deal. So we are really happy that he is here with us today. He's going to take questions at the end of his presentation. So put up your virtual hand after the presentation if you've got a question. He really encourages an interactive session, so please. He's also going to put up a couple of poll questions, and also because SAMHSA is a government-funded organisation, there'll be a survey as well, because they like to know who is taking these courses and what are you getting out of it. So did I cover everything, Jamey?
Yeah, you did great, Helen, and thanks for having me. All right, well, let me roll in, and I'm gonna let everyone know too, you might hear a little background noise. This is a real backdrop. I am in a reading room at a golf course in Hamilton, New Jersey right now for an event for this same SAMHSA center. So they've given me some private space, but the event is going on. So hopefully it doesn't get in there too much for you. But yeah, as Helen mentioned, we're going to focus today on treatment considerations for people with OUD in the rural communities in New Jersey. And you can see kind of our information there on the name of our center, the Northeast and Caribbean Rural Opioid Technical Assistance Center. And I'll talk more about it in a bit. Okay, jump ahead here. All right, so our primary objectives in this session are we want to overview opioid use disorder treatment more broadly, not with necessarily a rural emphasis, and then some considerations for the rural towns, counties in the US, but with real focus in on New Jersey, since that's our audience here. Then I'm going to overview some of the resources that are, national, kind of, we're part of this regional center, but it's a national network of centers funded by SAMHSA, kind of what we can offer to rural stakeholders in New Jersey. And, this group here is mainly a health professional audience that may serve urban, suburban, and rural. So it really just gives info that you could kind of share with other partners or use for yourself. And then we'll try to save at least 20 minutes for a community conversation at the end. So I'm going to try to get us through the slides in that first half of the time, and then really flip it after that for questions, just thoughts that people have, and to let us dialogue together. Some on myself. This is actually a screenshot or a picture, as like a Google image, but of where I grew up in Michigan. That's our one blinking red light. And we are a federally defined rural zip code or census tract. So that's kind of where some of my origins are. It's actually a town that's similar to a place like Hamilton. Hamilton's a little bigger, but a similar kind of size. All my training, bachelor's, master's, and PhD are all in schools of social work. And these kind of efforts to disseminate findings and kind of take research into practice is really kind of a guidepost for me. And yeah, even though I mentioned growing up rural, in that area, we're also medically underserved community. So even if you grew up or are more familiar with urban contexts, we shared some of that, that we just had a shortage of healthcare providers and a high burden of medical problems. I always put these here. So Michigan is where I said I grew up. If you can see my cursor, we were about right here, just north of Jackson, between Jackson and Lansing. But you see a lot of rural areas in northern Michigan. So Michigan has a large section of rurality compared to New Jersey. New Jersey, mainly the rural sections by most definitions are in the south, kind of where I'm at, as well as some of the counties like Warren and Sussex that are on the Pennsylvania border in the north. And then I actually live in Hunterdon County, which is another one of our state-defined rural areas. This image actually is from Hunterdon County. This is the mill, Red Mill in Clinton, New Jersey. So this is a nice picture I always like to have. So this is for our chat. These aren't formal polls or anything, but just you can put them in the chat. So which type of services do people in rural areas use to recover from opioid use disorder? Please post in the chat. So go ahead and put those ones in there, what you think, and I'll kind of give a gander to just see what folks think. Option A is 12-step or Narcotics Anonymous. B is the type of work you might do in social work, behavioral care, and outpatient residential. Medication treatment like methadone and buprenorphine that could be at specialty clinics or office-based. Natural recovery means to kind of not use any formal services, but kind of just try to do it on your own. And informal supports, church-based connection or social and family support. So I'm seeing E, D, A, E. So we're getting a lot of more E. Let's see if we get anybody else. Okay, I'll go with those. So E was our most common. Oops. And it was kind of a trick question. I didn't give you an F, which was all. But yeah, it's all, right? And I think but the idea that folks emphasized E and D and A, I think is completely in line with what's most common. So in some ways, that's the correct answer if it was which is the most common service for folks to use. But any and all of these can be used in rural areas. But decidedly, the most likely is that folks are, because there's a lack of health professionals in rural settings, options B and C are quite hard to do unless you travel off site to urban areas, right? Or you use telehealth. So 12-step, natural recovery, and then kind of informal supports are definitely the most common. Now we have one other chat. Let's just see. Oops. So some just context, and this is stuff you're all going to be very familiar with, but this data is actually a year outdated, this screen grab, but the numbers increased again nationally. So more than 100,000 people died in yearly overdose deaths. Interestingly, New Jersey in the most recent wave of data was one of the few states that did not have an increase, had a slight decrease. Some of that, I think, is because we were earlier on in the epidemic, because of access to fentanyl is more common in larger cities. So we had that a bit sooner than the spread into other states. This is a map of overdose death rates across all 50 states. So you can see New Jersey kind of here in that kind of lighter color. It's kind of higher up the map. If you look on the right side, the column shows the actual rates. You'll see Jersey down there. That's not the bottom. This is, I think roughly the top 20 states. And so Jersey's still kind of in the upper half of states. If I'd have given you this talk a few years ago, we'd have been up in the top 10, top 5 at times. So we're still a higher risk state than average for the country, but we have kind of scaled back a little, which is it's positive in a way. Our death rate actually hasn't changed much. It's just the death rates have increased in other places more than they have here. But you will notice kind of also on that map that disproportionately the death rates are higher in the eastern half of the country. Some of that is, as I mentioned before, just more access to fentanyl. And with the potency of fentanyl, there's more likelihood of death. This is a slide that shows you kind of different types of treatments for opioid use disorder and their relative effectiveness. What you see here in this map is methadone, which is a medication used to treat opioid use disorder, and buprenorphine, which is the generic name for Suboxone or part of the formulation for Suboxone. Those lines here kind of are much lower, they're flat. And you're seeing kind of the number of relapses is what's being graphed in the height. So non-medication treatment, so kind of talk therapy, even CBT, is that green line. What that means is that relapse is much, much more common when not using medication treatment. Over time, now you're getting to about 3 years out, you start to see that kind of non-medication treatments start to match if somebody is staying in treatment for that long. But as we know, that's uncommon, and it might take 3 years and you still don't even have the same effectiveness as what you see kind of in the early months of medication treatment. So medications have a strong evidence base for opioid use disorder treatment. Despite all that, there's still lots of barriers in terms of people accessing them. And there's a lot of misconceptions among the public and even among social workers about how effective those medications are compared to behavioral treatment alone. Again, maybe kind of review for some of you, but there are 3 FDA-approved medications for opioid use disorder. Methadone, which currently is delivered only in specialty clinics called opioid treatment programs, though there are drug policy solutions coming out that might flex that, make it easier to access methadone, which would be in line with how many other countries do it. The evidence suggests that there probably is not much risk to doing that, but there are still some misconceptions about why it should be regulated to such a degree. Buprenorphine, which probably folks are more commonly hearing it as Suboxone or Subutex. Those are the brand names involving buprenorphine. And then naltrexone is a third. The evidence is less strong for naltrexone compared to methadone and buprenorphine. The brand names for that medication, Vivitrol and Revia. Methadone and maintenance treatment is considered the gold standard by the World Health Organization, American Society on Addiction Medicine, and the National Institute of Drug Abuse. They buffer mortality, meaning kind of folks' likelihood to stay alive, reduce relapse, and retain folks in treatment better than naltrexone treatment, detox, behavioral treatment alone, or 12-step. That's all in the article by Wakeman there below, which shows kind of the relative effects. Let's see if I've got any. And that question, I see a question coming up. That's a great question. If you can just remind me to talk about that one at the end. Well, I can say it quickly that the addition of behavioral health treatment doesn't help a ton. It does help if you have behavioral treatment as an adjunct, but mainly the medication treatment is what's providing the lion's share of the effectiveness. All right. So with all this in mind, and I think folks are wondering, well, where is rural in New Jersey, right? Uh-oh, we're getting the lunchtime spill. Hopefully you get more ambient noise. But where is rural in New Jersey? So these are the standards that we use in our projects. So actually, none of the counties in New Jersey currently are considered federal by federal definitions. I am wondering, Helen, how are we doing in terms of background noise? I don't know if we can do much about it, but I just am wondering if I should speak up.
It's fine by me. Is anyone else having a problem? Put it in the chat. Yeah.
Maybe it's
seems
just
like it's
more
all
for
right.
me.
Yeah, I know. It probably must be quite disorientating.
It's okay, as long as it doesn't impact, okay, and I'll just kind of know. I think the lunch line is out here, so I'm competing with that. But yeah, so by federal definitions, there are no counties in New Jersey considered rural. We kind of fought with the feds about this there are considerations to change this. But in our center, we said, if we're going to do rural work in New Jersey, how do you want us to do it then, if you're not saying any of these areas are federal? So the State Office of Rural Health, which is through DOH, defines 7 of our 21 counties as rural. So we emphasize those areas, and we emphasize towns that are considered federal or rural by federal standards that are in counties. So Hamilton, Bridgeton, and New Egypt are a few of those. But you can see the first 7 counties there. These are defined as rural by DOH. Atlantic, Cumberland, Cape May, Hunterdon, Salem, Sussex, and Warren. So those are kind of our emphasis areas if you're doing rural work. This is a slide that shows kind of death rates for opioid use disorder or opioid related deaths, drug deaths. And I kind of mapped it onto the rural counties so you can see how this takes place. Now, these are rates of death, not numbers of deaths. So often when you see statistics about where overdose deaths are most common, they just count the total number. The problem with that is that there's a lot more people in urban counties. So even if the rate is lower, it can look higher. Both are important metrics, but this shows how many deaths, at a per capita level. So the highest rate, and these are the most recent data on the DOH website. So it's from 2019. It takes some time to confirm deaths. So there's a little bit of a lag. Camden is the highest, but you can see Salem, Atlantic, and Cape May are 2nd, 3rd, and 4th, all rural counties. Even though only 1/3 of our counties are rural, 3 of the top 4, roughly half the rural counties in the state, are in that top 4. You also see Burlington, which by some metrics is rural, Cumberland, and Ocean. So what you're kind of seeing is a bit of a disproportionate load from our rural counties onto this top 10 of the state. Hunterdon is an exception. Warren, those are counties that have low death rates but are rural. But it does show you that there's a need in our state. Kind of this intersection of rural health and addiction comes together. Some other considerations. So if you look here, this chart on the left, non-metro is code for rural. Metro is kind of code for urban. Sometimes you see these used interchangeably. What you'll notice is alcohol use is actually more common in rural areas than it is in small metro is sometimes code for suburban. It's more common. Cigarette smoking, much more common in rural areas than in urban areas. Smokeless tobacco use, much more common. Marijuana, less common. Same with illicit drug use, which some of that is just access. There's not a distribution channels there. Misuse of opioids is pretty similar across geographic contexts. So large urban areas and rural areas are about the same. Some of the more micropolitan or suburban, a little higher in the national data. You'll see that cocaine is a little lower in rural, but methamphetamine much higher. So just some different patterns in rural urban areas. Some factors that contribute to risk for substance use in rural America, lower education, poverty, unemployment, lack of access to healthcare, and social isolation. I kind of all told the message is this is not an urban problem. It's a problem kind of everywhere, but there's specific needs in each area. So our second question here for the chat, please post in the chat ways social workers can facilitate solutions to address treatment barriers for OUD listed below. So all these 5 below are barriers to OUD treatment, but why don't you write out some ideas for how you think we can help address these barriers?
This isn't a trick question this time, Jamie, is it?
What's that, Helen?
It's not a trick question this time,
It's
is it?
not. No,
Yeah.
I have some solutions on the next slide, but if
Okay.
folks want to take a guess at what they think would help, then we'll kind of just see. And I'm going to give us a second before I put on my solutions. I'll give us like a minute. So I see better education in schools coming up. So kind of more of a social determinants of health kind of angle from E. Wisniewski. Option A. So let me just jump to the next one. Let me see. So here are some of the things I think that we can do. Okay. So there's a shortage of trained workforce in opioid use disorder in rural areas, meaning there's not many social workers, doctors, nurses that know much about opioid use disorder in those areas. Some of that, there's just a shortage of workforce for everything in rural areas. So to find a provider who has a lot of training in opioid use disorder in a rural area is just not common. So one of the things we're doing today is to address that. You're getting trained on OUD treatment. So if you go to work in a rural area or already do, now you have a bit more knowledge than maybe the average bear does there. Sharing of resources. So you can take the resources from our center, share it, read it, and say, hey, you know, I know there's been a big problem with overdoses in this area. They're not sure where to go next. Here's a group working in that space. Eventually, folks like you could become trainers. I also think it's important for us to expand addiction content in social work curriculum, which is happening, but it's still something we can do better and better. Distance and transportation hardships make it harder for folks from rural areas to make it to treatment. So expansion of telehealth has been a big help there. A lot of folks in rural areas have misconceptions. This isn't just a rural issue, but a lot of folks in marginalized communities have misconceptions and maybe mistrust of evidence-based practices. They kind of feel it's not tailored, doesn't kind of bring in their values. So I think it's important that we try to culturally tailor, and there is rural culture, even though it's more of a place-based thing and not an identity from like a sexual gender, you know, or race ethnicity. There is still rural culture. So to try to tailor some of our approaches to meet the values and culture of rural areas, and then promoting knowledge about evidence-based practices using community engaged approaches. So kind of meeting people where they are. There's still not a lot of research about the opioid use disorder treatment needs for rural communities. So developing and joining kind of rural focused research projects. All of us can do more of that to kind of find out, what do people in rural areas want? How do they want treatment systems to be designed so that it's not a top-down solution coming from, you know, people kind of at the government level or academic levels who really don't get how those treatment systems should be modified. And then we just need policy changes. There's a lot of policy changes right now. There's over-regulation of medications that makes it really challenging for people to access treatment, especially when they live far away. If, for example, like other European nations, we allowed methadone to be prescribed at pharmacies, people in rural areas would have massively more access to that type of treatment. Some other considerations. So a survey in 2022 found that you know, more than half of rural adults said they knew little about resources for dealing with opioid misuse. 3 out of 4 believe that having access to behavioral health treatment would help them. And similarly, a lot of people felt that messages about recovery needed to be there to kind of decrease stigma. In rural areas, it's more common for providers to give opioid prescriptions for pain. which is good if somebody has pain. It's bad if, in terms of getting more opioid pain medications into the community that people might misuse. There's a significant shortage of providers, which we've talked about. I think in one of the papers we had, in all of Michigan's 57 rural counties, only 2 had a methadone clinic versus about half of the urban counties did. Jersey, you see similar things. There's more concentration of these services where there's more people. Sometimes folks from rural areas have to, not only drive farther, but like if you think of Salem County, you might happen to be driving across to Wilmington. Might be easier than going to Vineland or to go to Camden. So you're doing state line commuting. Rural areas also have a higher risk for stimulant involved overdoses. So opioids, mixed perhaps with methamphetamine. And just generally, people living in rural areas are more prone to deaths by despair. So deaths by despair are often, addiction related deaths, cardiovascular, like kind of other issues that just, as the social determinants of health are really in high risk, and there's a lot of economic decline, depopulation, threats to identity, that a lot of these deaths by despair are more apt to occur. This is a screen grab from a paper of mine where we looked at different types of barriers for opioid use disorder treatment in rural America. This was in the literature from just across the country. And really what we mainly found was that there were just big barriers to not having treatment providers, but also rural consumers had, more likely to travel, and even offered medication treatment less likely because the providers themselves didn't think it was feasible for those clients to make it to treatment. So they would say, well, we'll try to do 12-step or behavioral care for you because it's not feasible. And at the clinic level, so folks like yourself in the health professional space felt like they couldn't take on opioid use disorder treatment because they didn't have backup, they didn't have the ability to integrate these services to primary care, or that it was complex and risky. They felt like, I don't want to go into the addiction space. It's going to be too challenging. And then a lot of providers had negative attitudes. They believed that medications weren't effective, or that people with addiction were not trustful, and so they kind of didn't want to work with them. Just a few other things that folks often don't know is that rural residents have a increased risk of traumatic injuries and death, much higher risk of suicide, greater occurrence of a variety of different traumatic exposures. Rural women are more likely to experience high rates of interpersonal violence, greater frequency of physical abuse, and not have a lot of access to care. And rural children are also overrepresented, and they're likely to experience maltreatment and other forms of abuse. One final thing here is that, as I mentioned before, rural communities have kind of hesitancy and mistrust of some public health interventions, which you saw come up during the pandemic. And this mistrust isn't new, right? I mean, there's been kind of a move away from health services in rural areas, hospital closures, kind of shuttering of primary care, and really kind of pushing folks towards urban centers for their care or telehealth. And so because of that, there's kind of a belief in rural communities that the healthcare system was not designed for them or by them. Therefore, why should they trust a provider who's coming in to offer solutions? Some of the ways we might address that is more community engaged partnerships, trying to get more folks who grew up in rural areas into the health workforce so that they have an understanding, more research, as I mentioned, and really reform of healthcare delivery so that it does more what is needed in rural areas. I think right now the healthcare system does a much better job of meeting people who are in urban or suburban areas, even though there's problems there. So as we've seen, there's a lot of unmet needs for folks with OUD in rural areas. To address these gaps, SAMHSA kind of built a rural opioid technical assistance centers across the country. So really the whole country and territories, states and territories is represented. Each region has purview over their own specific states and territories. So with that in mind, this is a screen grab from our website. we're called the Northeast and Caribbean Rural Opioid Technical Assistance Center. You can see we serve New Jersey, New York, Puerto Rico, and USVI. This is our team. Dr. Mike Chappell is a project director. He's at Columbia University. I'm the co-director and then kind of tasked with overseeing New Jersey. And then we have another partner who oversees activities in the Caribbean territories. We work with the cooperative extensions in New Jersey and New York. So those are parts of land grant institutions like Rutgers that really have strong ties to the agriculture and rural communities of the states. It's just a disclaimer that just says that, you know, whatever our center does isn't a direct reflection of SAMHSA. Here's kind of the grid of how these regions work. You can see the 10 regions from the U.S. Department of Health and Human Services, and this is where each of these rural opioid centers is located. You can see us as Region 2, kind of Columbia, New York State Psychiatric Institute. But you can see kind of how this breaks down, and it's cool. SAMHSA does this to make sure that regions are working together, but it allows kind of the whole country to connect. So really the purpose of these regional centers is to develop and disseminate training and technical assistance. It's mainly about opioid use, but we have kind of the ability to focus on anything related to substance use and really more broadly kind of wellness and mental health. You know, we put an emphasis on prevention, harm reduction, treatment, and recovery for OUD and stimulant use disorder. And we try to make sure that we're offering high quality trainings or that we're training folks who then can provide those types of efforts back to their community. Our target audience are rural populations affected by substance use and behavioral health. The communities deemed rural by federal and state definitions, but you know, like I give events sometimes in New Brunswick, but it's about rural health. We can still do that too. We try to make sure that our trainings can meet partner needs. So we can do in-person or remote webinars, and we have flexible definitions for what we can train on. These are the 3 tiers of partnerships that we work with. The first is where I'm at today, the cooperative extension. So I'm down here in Atlantic County with folks from different county level extension educators in Atlantic, Cumberland, Cape May County. And that's been one of our main connections. And largely that's because previously the healthcare system and the cooperative extensions haven't worked as closely together. So we're emphasizing that connection in the beginning part of this grant. Tier 3 is where most of you are going to be, behavioral health service providers. We have more connections with those organizations. So we're still spreading kind of our information there, but in some ways have to do less capacity planning because like I'd mentioned, Helen and Jeff and I have worked together before, so we didn't have to kind of start from scratch. We knew that this would be a good fit. We also work with community-based partners or organizations, faith-based, schools. So we really try to make sure that with these 3 tiers, we can connect to rural health kind of in a variety of domains and not stay kind of like in the academic or healthcare silo, which is traditionally how this has worked. SAMHSA's had prior training and technical assistance programs on addictions. They weren't urban or rural specific, but what happened is most of those are located in urban areas. So the training in TA tends to be given to urban audiences that are nearby kind of where the institution is. Here's some of the types of events that we've given already. We have one that was rural communities, substance use and social determinants of health, defining, identifying, and managing risky substance use. We gave one last week to a lot of the agriculture and farming educators through the Rutgers extension about how substance use may represent a coping mechanism for stress experienced by farming and ranching communities, which they're disproportionately more apt to experience economic stress. And then how the rural context influences attitudes about substance use and or help seeking. So, you know, what is it about the rural context that maybe makes people not want to seek certain types of care or makes them more kind of likely to say, this is an acceptable way for me to recover. Here's some resources, and Helen is going to share all these slides, so you don't have to, you know, I don't even know that you can click on them right here now anyhow. But the first is our website for the center. There is a New Jersey specific page if you're interested in that. There's a brochure that you can download that's like a one-pager that shows everything we do, that you could not only for yourself, but you could distribute to anyone you thought this would benefit. There's a schematic that shows kind of the rural areas in New Jersey. If you're wondering, you know, is where I'm at a good fit? Like I said, we really can do anywhere, but if you're in one of our high emphasis counties, even better. And then there's just some other resources through the Rural Health Information Hub. That's just a great website for, it's not just about this or opioids, anything health in rural areas of the US. If you just want to get on their listserv, you can hear about kind of initiatives or new knowledge development. So Helen and Jeff, that is it. 12:35 was my goal. I did it. I'm glad. But for everyone here, this is what this is. So this is probably about a 3-minute survey. You know, I know nobody wants to do surveys they don't have to do. It's SAMHSA requires us to send these out. They want to make sure that A, that we're doing these events like we say we are, and B, you know, are people learning anything from them about the center, about opioids? So you can take a photo there of the QR code and it'll bring you right to it. You can also find the link. Now, Helen, I'm realizing that link, if I try to copy it, is giving me like a Rutgers-based proxy link. So I don't know if you have that link in the email I sent you yesterday. If you could just paste that into the chat, I think we'd be good to go. And you all can complete it at any point during this while we're having the conversation. It doesn't matter. Now that we've got through the slides, I think you're good to go.
Brilliant. Thanks, Jamie. If you've got questions, because there's some come up in the chat, please raise your virtual hand and we'll ask you to come on mic. But just for point of clarification, will you be making recommendations after you've finished in 2024? Is that the end goal, or is this a purely research-based project?
That's a great question. So this is a 2-year project right now. In all likelihood, SAMHSA will recompete this, meaning put out a new announcement next summer for a 5-year grant. Generally, how these things work is once you become the regional center, you're kind of the incumbent, and you know you have to either do a bad job or someone else has to put a much better argument about why they should have been the lead. We were really the main group applying this first round, so I don't suspect the second option to happen. I think our plan is, one, we want to stay in charge of this center just because we enjoy it, but two, to sustain the connections. So we go right now through September 2024. Many of these regional centers have been funded for like 20 years. This is just new. So as long as SAMHSA decides to keep doing it and nothing, for some reason we don't want to do it, which I don't know why, we hope to be in this game for a while. And that's why we've taken like an intentional time in the first 6 months to build partnerships more than blast events, because our view is, you know, things that we've did in New York City or in Newark, some of it applies, some of it doesn't. So we wanted to meet people and say, like, what do you want? So like the event I'm at here today, most of the people here are agriculture workers. So they don't have a strong level of like background in DSM, for example. So if you came in giving a talk on that, people would say, this isn't for me. So we really want to kind of meet those folks, say like, what do you want to know? And they might say, well, I want to know we've had a few overdoses among farmers in our community, but we don't understand why. And maybe they bring up something about stigma. Okay, let's give a talk on stigma in the rural context. So we kind of tailor and develop.
Okay, cool. We got a question in. Why have deaths gone down in New Jersey, do you think? What are we doing right?
I think so. They went down very, very slightly. So one, even though they're down, I would say it could just be random, right? It's not a major decline. Two, we were really high. So we were high before. When I came, so I was a faculty member in Detroit for a few years before I came to Rutgers. At that time, New Jersey was much higher. We were like 5th or 8th, something like that. And we've kind of just plateaued. it's not as much that we decreased, but other states went from below us and they skyrocketed. And some of that is some of the rural states have went way up. In the western half of the country, 5 years ago, they didn't have a high rate of this issue. But because fentanyl has spread to really every pocket of the country, now everybody's feeling it. I think some of what we've done well in New Jersey to at least mitigate a further increase is we have a lot of programs in the state around naloxone rollout. We have a lot of educational efforts around buprenorphine and methadone. We've got centers of excellence at Rowan Cooper has in the south, and then Rutgers New Jersey Medical School in Newark in the north. So you've got these groups that are really doing similar types of things of what we're doing here, but not rural focused per se. I think the other advantage that we have is that even though we do have a rural section in the southern part of the state, compared to my experience in Michigan, the transportation barriers, while big, are not as big as they were there. There were people in northern Michigan that would have to drive 4 hours each way every day, which of course no one could do to get methadone. Here it's bad in rural in South Jersey, but relatively speaking, it's probably not as bad as it is in like, you know, parts of the South where there's hours of travel every day.
Right.
And we also are a state, we have a lot of income inequality, but on average, some economic indicators on the whole for the state are higher than other states across the country. So we might have a bit of buffering from some things, but it's kind of unequal in the state. So it's sometimes hard to see in the data. A county can look like the average income's pretty high, but then certain neighborhoods it's really low. So it's hard to know.
Right, great. Marilyn asks, have you come across any data on the drug trend becoming an issue in rural areas? I understand uses has increased in urban communities.
Frank, I'm going to say, Marilyn, you may have stumped me there, unless trank is a jargon for xylazine, which it's possible, because xylazine is a drug that has started to really come into the supply and mixture with opioids. It has kind of an ability to affect the experience with opioids, but it can increase risk for overdose. But part of what's happening with overdoses is that opioids are being adulterated with a variety of different substances. Cocaine is, so people will purchase cocaine, it's laced with fentanyl, it's laced with xylazine. Sometimes they somebody purchasing it knows that or prefers that. Many times they don't. At a talk I was on last week on harm reduction, we were talking about overdoses kind of in two types of communities. One is somebody who has a long-standing history of using drugs and has an overdose. Another is someone who's relatively inexperienced in how long they've used and perhaps purchases something to use and it's laced and they don't know and or they don't have tolerance for it and they overdose. So I think, and that issue I think kind of cuts across rural and urban. You see that younger folks more in that latter group, they might buy cocaine thinking it's cocaine, fentanyl mixed in, they have no tolerance for it, they overdose and die.
Interesting. Arnez says, how do they collect data for deaths? I live in a county which has a large hospital. Therefore, we would receive individuals from other areas.
That's a great question. So it sounds like the question is about a migration effect for where overdoses are charted. So one, there's a lot of heterogeneity or like idiosyncrasy in the way that medical examiners code deaths, which is important because so many federal dollars are determined based on the rate of deaths in your area. So all those numbers I put up, they're bad, but they also dictate how the state decides where to roll out services, as well as how the state makes an argument to the federal government for how much money we need to address the opioid crisis. You do tend to see some examiners that will count deaths based on where the person died versus where the person's from, right? So that's been a critique of an underestimation of rural death rates because somebody goes into a neighboring urban county, say Camden, to purchase overdoses and dies, it's counted as a Camden death, even though that person might be from Cumberland, right? Or from Salem. I would say it's mixed. It's not uniform. There are not newer, but there's been a kind of renewed emphasis on fatal case review data recently, where there's groups coming together who review overdose deaths and try to have a variety of different inputs. I'll give you an example of how this can affect things. There's a county in the state of Michigan that was rated very high in drug death rates, like top 5 out of the 80 counties, so very high. Yet in opioid death rates, they were ranked below average. That would essentially never happen because most deaths involve opioids. Well, I did some work in that area. So upon talking to them, we found out that the medical examiner in that area did not believe in polysubstance overdose deaths being counted as opioids. So if they found somebody died from opioids and cocaine, they did not call it an opioid death. They called it a drug death. Well, unfortunately, then the National Institute of Health rolled out money. And what metric did they use to determine where you should implement services? Opioid deaths. So now all of a sudden, this county was not considered a high need county because of that, and it was all based on years and years of a medical examiner. It was just their own opinion.
Interesting. Candice says, can you provide guidance for access to Narcan for parents now asking about how to keep their children safe? I don't know if you've seen the French couple who lost their baby. They were staying in an American Airbnb. So yeah, have you got any guidance around?
Yeah, so Narcan, or as it's known generically, naloxone, there's been big efforts by the state to roll out access to Narcan kits. But one of the issues has been there's not been enough supply of kits relative to need. They're trying, if you've on LinkedIn or on different things, you're seeing a lot of policy issues about trying to make Narcan available now over the counter. And so that's supposed to be a big win to help folks be able to find it themselves. The problem is it's still at times priced at a level to where the average person maybe can't buy them. So there's still a lot of barriers. I do know some colleagues of mine in Detroit had built vending machines that had Narcan kits. So that was supported. I would guess, I don't exactly know the stream where it came from, but probably supported by federal and state dollars to roll out services. So they were providing kind of like a soda machine, but with Narcan kits. I think generally, Candace, to the question, there's not enough access. Rural areas are less likely to have access to Narcan. Emergency, part of that is like if you have an overdose in a rural area, it takes longer for EMS to get there. So you may miss the window where you can use Narcan. On top of that, there's just less likelihood that the EMS in that area is kind of, giving Narcan in the same fidelity that's occurring in urban areas. So you just see, it's kind of similar to everything. The issue is across all settings, but rural tends, anytime there's a specialty service that requires training, rural gets it near the last, right? Because there's not as much hubs built up. So everything that requires people to get together, work together to learn how to implement new protocols, it just goes slower because there's fewer people.
Mary put a question in the chat. Could you say again which treatment is most effective? And that wasn't about the Narcan, it was about the question.
Other ones from. So that's a great question. So, the 5 that I listed there, but generally, so effectiveness, meaning in this context, is the likelihood to prevent overdoses and or fatal overdoses. That's usually the number one metric used to assess how good a treatment is. And part of that is because death from opioids is so common. So in other addictions, you might have a different outcome measure because, you're not going to have overdose death from cannabis, right? So you don't necessarily assess effectiveness that way. But in terms of reducing relapse and preventing overdose deaths, methadone and buprenorphine, which is the brand name, Suboxone, Subutex, the most common you'd hear of, are by far more effective than the one other medication, which is naltrexone. Naltrexone is like an extended release. You can get it, take it, have it for a month. It's just not, it's a different type of medication that doesn't just doesn't work in the same exact way, so it's not as effective. But the benefits of naltrexone is anyone can give it, any health provider can give it, versus methadone and buprenorphine are very regulated. So only certain clinics or providers that go through have more training, at least historically, that's how it's been. So naltrexone is better in terms of what's easier to give, right? A clinic could implement that and start doing it because they don't have to jump through all these kind of regulatory hurdles. So there's pros and cons to each. Methadone is slightly more effective than buprenorphine, but buprenorphine can be provided in a wider range of settings. There's still some requirements around it, but you can get it at a primary care doctor. You can't get methadone at a primary care doctor, not at least now. But if you just look at which ones help prevent future overdose and relapse, yes, those two, methadone and buprenorphine, far superior to behavioral health alone. So meaning like outpatient, non-medication substance use treatment. And the reason that is just that if people stop using, this is one of the biggest things, and we had this in our misconceptions talk, Helen, is that if people stop using opioids, kind of they say, I don't want to use anymore, I'm going to detox, which is a common approach. They now say, I'm no longer physically addicted. The problem is that in detox, actually, if there's no linkage to other care, is shown to be a treatment that can actually harm people and increase the odds of overdose death. People lose tolerance if and when they relapse, which is the norm for people with opioid use disorder. They don't have tolerance anymore. So if they use the same amount, or if they use a supply that has fentanyl in it and they don't know, their body can't handle it. So that's the main challenge when you try to have somebody not use a medication, is if they relapse, it's much more likely to be fatal. What the medications do is blunt the kind of reward and the impact of using. So it just decreases the likelihood of an overdose death. And really the goal, I think, long-term is to try to work through in the first year or so, 6 months or so, to build back social supports, housing, mental health treatment. And then in time, folks may step down from those medications as they feel like their chance of relapse, or what we sometimes call recurrence, has lowered, to where they can use, where they either aren't going to use, or if they use, they might do it in safe ways, use fentanyl test strips, things like that.
Fascinating. All right, I don't want to put you on the spot, but it's not often we see the Northeast tied to the Caribbean.
Yeah.
Have you got any high-level information about what's going on in US Virgin Islands and Puerto Rico? And if you don't, that's absolutely fine.
Yeah, so it's a weird distinction that HHS blends some territories in the Northeast, others they blend with regions in the South. So there has to be some crosstalk between different regions that are in the continental states. By and large, one of the other issues for Puerto Rico and USVI is even some of the codes that the federal government uses to define rurality, they don't even list those territories in those codes. So I think to me, that shows right off the bat, are there full efforts to include those territories in decision-making? Well, if they're not in the codes, and the codes are required for this project, so we had to actually say, we will engage in the communities with smaller population density. In those areas, that's what we'll use. If they're a community with just fewer people per square mile, we'll call that rural and we'll connect there. I think the biggest takeaway for those territories is that the social determinants of health there are high, meaning there's a lot of burden from other kind of social and economic things that increase risk for substance use. So there's a strong need for services there, because just like any kind of under-resourced community in the continental states, where that's going to come up.
Cool. Very good. Got that on the fly. So
Yeah, you did. You didn't send me that one in advance or anything.
No, I didn't. So you've got social workers and those in the helping professions here. How can they help your project apart from doing the survey? That's really important because your funding can rely on that kind of stuff. But is there anything else you'd like to invite them to do?
I think the biggest thing social work as a field can do, it's a couple things. One is we still have a really high level of misconceptions about opioid use disorder in our discipline. People still often have a lot of stigma towards folks with addiction. They believe that they should just stop using. They believe that methadone and buprenorphine are a crutch and replace one addiction from another, things that are not supported by data. I think first and foremost, it's important for our discipline to really address the embedded stigma and at times kind of racist and classist attitudes we have about addiction. I think that's step one. If we don't do that, you can try all these new programs, implement everything, and what you'll find is no one does it. There's money, people don't use it because they don't believe in it. They think we don't need this stuff. All we need is folks to just go to NA. If they go to NA or if they go talk to a social worker, they'll be fine. And that, even though the research data doesn't suggest that. Second, the other thing, a big barrier is clinics, even if they want to roll out services like Narcan, or they want to roll out buprenorphine, one of their biggest concerns is that the doctors, the nurses, the medical providers who can prescribe don't want to do it because they don't have the necessary infrastructure from their other members of their health profession team, social workers, case managers. So, and a lot of times, if they don't think that they can rely on those folks to know how to provide counseling for, say, comorbid depression and trauma, those things all increase risk for opioid use disorder. And they're things that social workers are absolutely equipped at leading those treatments. But if there's no social worker there, or if that social worker isn't trained in cognitive behavioral therapy for PTSD, the doctor might say, I'm not going to start providing buprenorphine in my clinic, because once I do, that client is going to say, thank you for the buprenorphine. Can you now address my PTSD? And they'll say, well, we don't have the infrastructure. So I think what social workers can do is really be the bridge between all of the other services that people with addiction need, and help then the medical provider kind of say, you deal with the psychosocial side and I'll deal with the medicine side. And I knew a provider in a rural area once who he did all of the treatment, the medication himself, but he was kind of just industrious, I guess, he just did it. But he said, basically, I don't have support. It was a primary care setting. He said, I don't really have anybody to do it. Now, so if a social worker is passionate about this issue, they might be kind of the face in the community or the county to say, I'm going to train, people, I'm going to train the case managers at your site. I'm going to train peer recovery specialists or navigators. Just being a part of that system and trying to kind of fill our role, I think, is big.
Brilliant. We are so lucky to have such a distinguished expert for this conversation today. No, really,
The books help right behind us, Helen. It gives us a regal feel.
Exactly. So, I'm going to send out this survey. Please take the survey, as it's really important. And also, if you're interested in having Dr. Lister come and talk to your group, I mean, you're going to have his email address. It's really important to get out there and do as many of these presentations as possible. So thank you, everyone who could join us. I'll send out the slides and the survey after we finish. And thank you so much, Jamey. It's always such a pleasure to work with you.
Well, thanks, Helen. And I'm going to tag on to one thing you said there, because I didn't. Anybody who wants us to connect with your organization, absolutely. Email me, or if you can let us know how to reach you, we'll set up meetings with you and say, hey, we'll come down and deliver a talk or training to people in your healthcare organization about something. It doesn't have to be this, but something related to this. Whatever you need, we'll figure it out together. So thanks again, Helen, and thanks everybody.
See you later, everyone. Bye-bye. Good luck, Jamey, for the rest of the afternoon. You did ever so well, considering there was